Hello, everyone, and welcome to the Bayesian Musings podcast. I'm your host, Vishnu. Today's episode is another one from the archives of 2020, is with Dr. Chris McRae, who again was an ED advanced trainee at the time and is now a fully fledged ED physician working in Geelong. I met Chris when I was working with him in Geelong as a junior ICU registrar, and was always impressed by his calm and laid-back nature and for being thoughtful and nuanced in his approach. I think this is highlighted in the way he talks in this episode, and certainly is a lot to learn from for myself. And as it comes up in the episode, this goes beyond just work. He's a husband and a father, and it's interesting to hear about how his outlook on work has evolved over the years and the priorities around work and life and the balance of that. Anyway, I hope you enjoy the conversation and find it as useful as I did. Hello, Chris.
Hello, Vish.
Thank you for doing this.
Thank you for asking me. It's a pleasure.
It's an honor to have you. How are you today?
I'm good. I'm good.
Excellent.
Thank you.
Thanks for making the time. So we'll get into it if you're happy. Do you want to start by telling me a little bit about your life story?
Yeah, so in brief, I mean, I was born in... it's meant to be brief, but, I'm from 3 hours west of Sydney in country New South Wales.
Yeah.
I have 2 younger brothers, mother and a father. We had a wonderful life in a small country town called Blaney. School there, it was just idyllic, classic country childhood. Somewhere along the line, I ended up with an idea that I'd pursue medicine, which I studied in Sydney. And for reasons which are largely unknown to me, I ended up working first in Albury-Wodonga and then in Geelong, largely. And so now I live in Geelong with my wife and 2 children, and have been here for 4 years or so.
Yeah. Can you tell me a little bit more about how that journey into medicine happened?
Yeah, like why did I do medicine?
Yeah.
I think there's different answers to that, depending on what stage of my life I was at. I mean, I had to interview. Did you have to interview? Did you do an interview?
Yeah, I did a few.
Yeah.
Because I did high school in Western Australia, but for family reasons, I had to interview around to get to Melbourne.
Yeah. Yeah, so I had to interview, and I remember being asked, and the answer, is of course you wanted to help people, which I'm not saying that was completely false. I just think that was very idealistic and probably not what a psychoanalyst would have to say about my reason to pursue medicine. I think also the answer which I gave for a while at social functions, which is that I wanted a job where I'd had a higher chance of getting a girlfriend, was, again, also partly true, but also partly just something I said. I don't know. It was kind of there, and I think I had something to prove to myself or someone else, or it was an appropriate size challenge at the right time. I think was why I applied.
Yeah. And so it sort of developed throughout high school, did it?
Oh, like there was this, so my mum is a wonderful mother. I can only say good things about my mum. And she had sort of like the idea, it was the rural medicine wave. Were you aware of that? Where, I think Tony Abbott was the health minister, and he had this scheme to create a GP for every small town in the country.
Yeah.
And so a quarter of the Commonwealth funded places in a lot of the universities at least were allocated to like there was a specific rural entry pathway. So I was a part of that, which I think made it like more of a feasible option for a lot of the people I knew at uni.
Yeah.
As opposed to, the elite sort of selective school sort of set, which was, I think, a significant minority or majority of the cohort.
Yeah.
And yeah, my mum suggested, like, that's how it came up. And it was just there, and it was always sort of festering as an idea.
Yeah.
But I only applied to one medical school. Would have been an engineer, I think, if I hadn't gotten in there.
Yeah.
And yeah, it was just fortuitous, really.
Which uni was it, if you don't mind me asking?
UNSW.
Yeah.
Yeah.
Excellent.
So, yeah, lived in the eastern suburbs of Sydney.
Yeah.
Would have been nice if I wasn't a poor student.
Yeah. How was uni life?
It was great. I had as I've sort of hinted at, I just worked really hard at school. And then the idea that you'd turn up to uni and it was just, wildly entertaining through in various ways that life had not been at that time.
Yeah.
And so, yeah, the first few years were a great time.
You met your now wife at uni, didn't you?
Yeah, Jess and I met at uni. We lived in residential college together.
Yeah.
Life blossomed.
Yeah, I remember you telling me that how life is different after that event happens.
Well, after you get married, or
Well, it was your recommendation that I needed a girlfriend to
yeah,
fix my
that's
life.
right. Yeah, yeah, I've offered you various bits of life advice, though, Vish. I wouldn't take it all too seriously.
Well, from what I've seen, I think I probably should take some more advice from you. So you said you interned at Albury Wodonga, is that right? And
yeah.
and then to Geelong?
Yes, I was there for 3 years. I'd sort of done rural placements there, and Jess was living in Melbourne, and the whole sort of state thing, it's very hard to cross state borders as an intern. So that was as close to Melbourne as I could get a job, basically. Was about the most thought I put into it.
Yeah.
It was a great place to work. I was there for 3 years. I was going to be a GP. All my medical heroes were GPs from up there.
Yeah.
The best doctors still that I've ever met. And yeah, for various reasons, that's not what I ended up pursuing.
Yeah.
But it was a great place to work. And so poorly understood by people who haven't. Having a little bit of perspective now on that the vast majority of medical people just live and work in like Metro Melbourne or Metro Sydney. It's just, I feel very grateful to have worked there and have had that perspective.
Yeah. And how did you end up in Geelong?
Well, I was to do ED training. I don't think I'd ever been to Geelong. I just had this idea, like this sort of, it was like a year of inner turmoil because I'd applied to and was going to be a GP, and was very sensible for me. I think I would have been all right at it. And then the first year of that, I did a year of ED, and the idea was that was something I'd always loved. But then a year of it, of night shift, of shift work, of the challenges that entails, I'd just be put off it enough to go on and do something sensible thereafter. But then halfway through the year, I'm going to these GP clinics and they're asking me why you want to do GP, and I was honestly lying to them. Yeah. And so then Geelong, I literally looked up the places you can train in the places where, because Jess and I had a 1-year-old at the time, that would be acceptable for us to live, where I wouldn't have to move too much throughout the training. That was a real concern of mine with young kids, was having to move too often.
Yeah.
And also, I had no interest in moving my family to Melbourne to live in a 2-bedroom unit. So it was the right balance of training opportunity and life for my family. And I mean that sincerely. That's why I picked it. And it has worked out that way, which is good.
Yeah. And how did you end up in ED from GP?
Well, again, it was just there's all sorts of, it's kind of like the why did you do medicine?
Yeah.
You make up answers to the question that you can give in an interview. Basically, I'd always liked it. And then eventually I was there long enough that I enjoyed it enough that it was the only option. It was the only place I could really pursue working full time. The only thing I really saw myself doing. And to intellectualise it more than that is probably not an honest way the decision went down.
Yeah.
Yeah. You can talk about the pros and cons and, you can write a list on the paper, but it's just what I wanted to do. I just love working in AD.
Yeah.
Still do.
What was the process what has been the process for you so far with the training and college?
The time I joined, it was very informal. You needed 2 consultants to sign a form to endorse you as a trainee, and you needed a job at a hospital which offered training.
Yeah.
The ED college has since gone through a process of formalising that, formalised application, formalised intake at a particular time of year. But for me, it was, I just had two people sign my form and got a job at an ED that did training, and then I was on the pathway.
Yeah. So at that stage, there was no sort of timing of application, was there? Or
No, no, any time of year that you
right.
got your form signed and submitted,
Yeah.
you became a trainee from that date.
Yeah.
Which like the person who signed my form was the director of training at Geelong, who, like in hindsight, like 2 meetings when I went for a tour and then for an interview to sign the form.
Yeah.
Like it was a really remarkable thing that someone did who'd not met me to endorse me as a trainee.
Yeah.
Like that was a big thing that person did.
Yeah.
Mm.
And post-primary, somewhere in the process of contemplating or sitting fellowship?
No, studying for that.
Okay.
So that's happening in May.
Yeah, right.
Yeah.
Good luck.
Thank you.
So I appreciate even more taking the time out to do this.
Oh yeah, no, it's I mean, studies like it's I love study. Like I've spent so much of my life studying.
Yeah.
My wife would say I'm really good at it, that you just love it. My mum would say that you just love it, and it's true. This is the first time where it's been a real challenge to balance.
Yeah.
Like I either feel guilty that I'm studying or guilty that I'm with my kids. Not quite, but it's been
Yeah.
balancing that it's been the first time it's been a real challenge.
Yeah. So it wasn't as hard with the primary?
No, because George was just one. And I mean, without talking about parenting too much, was still like kids sort of my view of it is that as a dad, you become more and more important as time goes on, like from being completely useless to, it's to your kids just, you go from not really contributing a lot to contributing a whole lot. And it's just so at the times that the primary and now the fellowship have been, I've been at different stages in that.
Yeah.
To me.
Okay. We can talk more about that if you're happy to, but I'll come back to that if that's all right.
Yeah.
So with emergency,
Yeah.
how do you feel, or what do you feel your role is as a doctor towards your patients? And how do you think that's different to other specialties throughout the hospital?
Yeah. I mean, you sent through the questions, Vish, and I see these questions and I'm like, I really don't know if I'm going to be able to do this justice.
That's all right.
Because there's a lot to that, and I wouldn't pretend to speak for how the specialty views itself or how my colleagues or mentors or view themselves. But how is my role in terms of the patient interaction?
So just to make it maybe a bit easier for you, it's not. I'm not asking you in regards to your whole specialty as a representative. I think the aim for this for me is as a colleague that I respect and look up to, and would like to learn more about on how you approach it. It's essentially your perspective is what is important, I guess, as far as that question goes.
Yeah. So I mean, in ED, like my role is you see the patient when you've got no information, and you've got to transform that into something that gets them on a safe pathway.
Yeah.
And there are lots of different sides of that, but the differentiation of illness is really one, like it's a huge part of the job. But then 90% of what we do really is sort out who's got something to worry about and who doesn't have something to worry about. And that sort of recognition of that, I think is poorly understood by people who don't use it as part of their, who don't have it as part of their work. Because it's not handed to you on a plate. You don't really know whether or not someone's got a problem. Everyone's got a 1% to 2% chance of having something terrible, and they look roughly the same as the people who don't have something terrible.
Yeah.
You're sorting a complex sort of input of, psychosomatic overlay complex comorbidity, acute symptomatology in a time-pressured, resource-limited,
Yeah.
information-poor environment. And then I see my job as to, out of that, pick the right diagnosis and start management and get the patient to a safe place. That's basically what I see my role as.
Yeah.
Different people, different people speak a lot about ED doctors as being patient advocates because they act basically as like they're the point in the pathway where the pathway is chosen largely, or at least that's how we see it. So patient advocacy is something I think a lot of people would rank fairly highly on what our job involves. I don't know, you get to see whatever people's problem is on the day, and there's a lot of, "Oh, why did that come into ED?" Not from me, but from other people.
Yeah.
And just basically, EDs have evolved to exist to provide a service to the community for the problems that they have today, whatever that be, whether it be a dislocated shoulder or a cardiac arrest or, amphetamine intoxication
Yeah.
that is unsafe to be managed in the community. And so ED has evolved to be the thing which deals with all of those problems. And so you just see whatever's next in that context. Mm.
Yeah. Can you think of much difference sort of between that and an inpatient service and how their roles might be different, or
Oh,
it's
it's
kind of hard
tricky,
to
isn't it?
talk,
It's
isn't it?
tricky. It's hard.
Yeah.
It's hard to talk because I haven't done that much inpatient stuff,
Yeah.
to be honest. And so a lot of that becomes my perception of, because I wouldn't want to say that other units or teams don't have that as part of their role as well. I wouldn't want to say that at all.
Yeah.
It's just that it's a big part of, you know, like it's so hard to explain. I was trying to talk to my mum and dad who aren't medical, like trying to talk to them about what my job involves is like, it's really hard.
Yeah.
They just don't know. And
Yeah.
a lot of people just don't know. Like, you got to get things out of people's eyes.
Yeah.
There's just this procession of 25-year-old blokes with bits of metal in their eye. And there's no one else between the hours of 5 p.m. and 8 a.m. when it actually really hurts to have something in your eye that can get it out. Like it's,
Yeah.
Yeah, I don't know how it really compares to inpatient teams. I mean, ED has an interesting relationship with inpatient teams, which we can go into if you want. I mean, I think that's a bit of what you want to talk about.
Yeah, that'll be coming up.
And that's coming up.
Yeah, but just on that note, this might be a little bit topical. You've talked about sort of patient advocacy and, sorting out through limited information from the patient and time pressure. How do you feel about that, the 4-hour rule, and how that impacts on your role as a clinician to your patients? Happy to skip it if you don't want to talk.
No, I'd like to talk about that at length, and I'm happy to.
Yeah.
Because I've got fairly strong views on the topic. But again, that's something I'm not sure I'll be able to fully say what I want to say. But rough ideas around it are, so I'm a big fan of efficiency and of patient flow, and that has to be enforceable.
Yeah.
So that there has to be a stick. So the ED I work in at the moment, and I mean, how many EDs have I worked in now? I've worked in 5. So like the ED I work in at the moment, at its peak, was seeing 240 patients a day. So that's been less through the shutdown of coronavirus, but now it's back up to those numbers. Basically, what you've got is a situation where there are 50 treatment spaces, including 16 short stay beds. And you've got 24 hours in the day that you've got to put those 240 patients through the ED.
Yeah.
So there are several options in the way that you can do that. And I mean, as a society, it has been decided, and I think it's appropriate, that patients who feel they need to turn up to a hospital and have care on that day can receive it at that day. Like, we can provide emergency care in this country.
Yeah.
And so then there has to be a means by which those 240 patients can go through those 50 treatment spaces.
Yeah.
And so that relies on efficiency. And so there has to be a stick by which that is measured. And for whatever reason, I think first through the NHS and now in Australia, that's come up through the 4-hour rule. So in terms of the population of patients as a whole that you see, that the ED sees on the day, it fantastically improves the care that they receive. You talk to old emergency physicians who, like in the 90s, they brought in the 8-hour rule. Like there has to be a rule.
Yeah.
Like it's not new that there has to be a rule. When I was at Albury Wodonga, it had the highest rate of 24-hour stays. I don't know if it was in Victoria or New South Wales, but in whatever state it was counted as. And it's a disaster to work in what at that time was a 20-bed ED with over 100 patients coming through a day where there are patients staying there for 24 hours. You just cannot provide care.
Yeah.
So it's like I have given, like you've got to, and so the criticism, people would perceive that you can do less for your patients with the 4-hour rule. And I certainly doesn't really bother me and doesn't bother most of my colleagues, I think, whether the patient's sorted in 4 hours and 5 minutes, 3 hours and 55 minutes.
Yeah.
Like I don't lose sleep over that. But like when you've got someone in a bed in ED who can have their care continued in another realm, be that at home or in short stay or upstairs, and there's an old lady in the waiting room with pneumonia who's receiving no care, and there needs to be some incentive for the system to move those patients through so that old lady can get care.
Yeah.
It's pretty grim to treat pneumonia in a chair in the corridor, but it happens all the time.
Yeah.
It happens all the time. Yeah. So I can discuss this at length if you'd like. And so, yeah, like the idea that, like, so I've gone from being very timid about it to having very strong views on it. I mean, patients need to be looked after in the system that we have, and that relies on efficiency. 4 hours, like, I mean, what do you think? Like, because people would have you believe that it's you've got to be careful. Because I don't want to also speak with generalizations about my colleagues in other specialties, because I think overall I have vastly positive interactions and I'm hugely impressed by some of the people I get to refer to and interact with on a day-to-day basis.
Yeah.
Very good clinicians, very good communicators, like really understand their role and they're an absolute pleasure to work with, and that is the vast majority of people. So I don't want to, I by no means want to place criticism or perception or create this sort of silo thing, which is a problem, like, because it doesn't help if everyone bashes ED and it doesn't help if ED bashes everyone else.
Yeah.
Because I'll speak again, I'll say it again, like very highly of all of those groups and people and individuals. Yeah, but I really think that's got to get beaten out of people, that the 4-hour rule is, I mean, you can't provide care in ED without flow.
So I guess I don't have as much experience as you do with the logistical issues of ED. So I think your answer is very insightful, and I think it's useful. Gives me more of an insight, I guess. I don't disagree. Like I agree. Like, when you have that many patients, there has to be a way to have flow of patients and turnover, like you say. And the question, I guess, is, does the 4-hour rule impede on your ability to provide appropriate care? Which, again, I think, and that's balancing out with the difficulties you mentioned earlier of, limited information from the patient. You're the first, interface between the public and the hospital. So you have to filter through all of that with the time pressure to an appropriate destination. Can that be done in 4 hours? I think you're much more qualified to answer that than I am. But I think with a lot of those decision-making aspects, it probably can be, I would have thought.
That's a very good question, Vish. That's a very good question. Can it be done in 4 hours? Yeah, because I was thinking about, can it be done in 2 hours? And it can't. There is a thing that it can't be done in.
But I mean, if you look at sort of, STEMIs or stroke protocols, there's certain things that can be sorted out within a very efficient time frame when it's protocolized, and there's a good evidence base to guide the appropriate management. But I think it's the difficulty comes into those vague presentations where you're unsure, like you say, any patient can have 1 to 2% risk of having something life-threatening. and they all look the same. How do you, that's, I find, one of the hardest parts of ED of, you have the pressure of discharging them home versus admitting them. And
Yeah, I mean, I don't. Yeah, it doesn't affect with my practice. I don't, and the system I work in. I think I can. I don't think my patient's care is affected
yeah,
negatively because of
yeah,
it. I think there are clinicians, and again, I won't restate it. My position on the quality of a lot of the other people in hospital, but there are people who think that ED could do more
yeah,
uh, for the patients. Like I had a very senior consultant say that we should be able to keep patients in ED for 24 hours. Like, I mean, I won't restate the efficiency argument, but
yeah, yeah,
that's frankly hilarious
yeah,
that that's measured as a. I mean, sure, it'd be nice for them to have a patient whose blood cultures are back handed to them on a plate. Um, but I don't really think it makes that much of a difference. You just got to set the system up right. So, like the surgical unit at Geelong has an open door policy to abdominal pain. Like, they're a wonderful unit with a wonderful attitude.
yeah,
They're like, we will help you. The senior people in the surgical unit
yeah,
send the patients up. We understand. We want these patients to receive the good care. We can see that our role in this system
yeah,
is to help you look after these patients. The patient can have their CT scan upstairs. It
yeah,
doesn't matter.
yeah,
Um, I don't know. Like, I think it improves my function as a clinician. I've just been at a different tertiary hospital, and like they're very efficient. Like they get people through, and you make all your management decisions without investigations.
yeah.
And it's really interesting because I follow up on all my patients, and it's just the management doesn't really change that much, from their ED
Yeah.
management. There are cases where it does, but and I suppose those are remembered. And people talk about those, but it doesn't really change that much.
Yeah.
I don't, yeah.
At least not in the sort of next 24 hours, at least.
At least not in the next 24 hours. I
Yeah.
mean, they might, yeah, maybe I don't know. You could go into it at length.
No, I think that's useful, definitely.
But does that make sense? Like,
Yeah.
that's not too, I mean, I did this night shift on the weekend where I was in charge, and it came on at 11 o'clock. The ambulance, like, ED was full. Uh, Waiting room was full. The ambulance bay was full. Like, there were all these patients who weren't getting care.
Yeah.
Like, they were just stuck. They were getting nothing. And so then there were a couple of patients who had to move through the system and get maybe slightly, you could argue that they could have had, ED could have done a tiny bit more for them.
Yeah.
You know, you could also argue that the unit who'd accepted their care could do that as well. Yeah.
Yeah.
You could, but the patients who are stuck were getting nothing.
Yeah.
You see kids, because we've got the ISO issue at the moment.
Yeah.
Like febrile kids, talk about a 1 to 2% chance of something terrible.
Yeah.
And having, it's hard.
Mm.
And these kids are waiting. I saw a kid waited 6 hours for an ISO bed.
Yeah.
Like, it's horrific. Some poor parent has brought in this child concerned that they'd got a fever and hurt themselves. And the answer is not, oh, fever is benign. Well, fever is not, fever is benign, but 1 to 2% of kids who come to ED will have a occult bacterial infection,
Yeah.
and that child has selected themselves to be a part of that population. Sorry, Vish, this turned into a bit of a rant.
No, it's great.
Well, you've just been to Gen Med Reg. I mean, what do you think? I mean, like,
Yeah. I think, part of that, I guess, would be the next sort of question as well, which you can summarize as well, is, what do you wish other specialties understood better about ED? And I think having done some Gen Med, and previously having done ED quite a while ago, so it's a bit of old experience. I think I agree. I think the expectation seems quite varied, at least from my perspective, to other physicians that do gen med on what to expect from ED. What I found interesting was even getting a referral from ED some of the time. Getting like this sort of very formal, long-winded handover or a referral. I'm like, just can you skip to the bit? Tell me what you think the working diagnosis is, what you've done, and what the plan is. And if that makes sense, I'm happy to accept on interims. But I wonder if that's sort of expected when you're making a referral to gen med, that you have to do a proper referral with social history and all that sort of thing. Which I'm not sure that's really necessary, because I think if you've got a diagnosis that you've formulated and you're doing the appropriate investigations and management, then the rest of it, the social history is important to get, but that should be the admitting team's, job, I would have thought, to, look into how that plays into their admission to hospital and how discharge planning and all that comes to the admitting team, I think.
Yeah, like I mean, there
Just gonna
are
turn the light
different.
on.
Yeah. Are we pausing?
Getting short-sighted.
Well, Vish, there are different ways to answer that question. I think different health systems are answering it in different ways. I have anecdotal evidence of a major metropolitan hospital that refers to gen med via a message,
Right.
without human-to-human interaction,
Okay.
which you can speak to pros and cons of that. I quite like interacting with the gen med registrars.
Yeah.
That it's a very valuable part of my job to get to talk to admitting people on the phone. It's overwhelmingly enjoyable. It's this structured conversation. It's great. I mean, I'd be sad if that was the way.
Sorry.
I'd be sad
Yeah.
if that was lost.
Yeah, I agree.
But yeah, then again, on the same time, it's like you hear people give these referrals and it's just like, oh, you don't need to say that, isn't it?
Yeah.
They've got pneumonia. They're 90.
Yeah.
They're coming in.
Yeah.
Yeah.
COPD, getting steroids, bronchodilators, antibiotics.
They're okay.
Yeah. Sats are okay.
They're coming up.
Yeah. Sounds good.
And I guess, yeah, I mean, you can, again, we're talking about it at length. There are probably a lot of cases that, can get away with that.
Yeah.
But I think it relies on the hospital, whatever hospital you're at. It's just no good to have a ED care. Like, it's the hospital care for the patient. That needs to be the way that it happens.
Yeah. And again, part of the reason for me doing all this is I think I've been quite frustrated this year with a lot of the negativity towards other treating teams, regardless of, I mean, as you've mentioned, ED is not the most loved department in the hospital, in any hospital, I imagine. But I think, like you say, it's a patient's care in a hospital that matters. It doesn't matter who's managing it really, or who's right and who's wrong. I think it should all sort of come to an agreement of what seems the most appropriate and the best way to manage a patient. And there should be more constructive ways to maybe discuss those. And I think, like negativity towards referrals, which I seem to hear a lot. Incidentally, there was, when I was on gen med, I made a point of putting on the message board, I've had 2 wonderful referrals from ED tonight, just to, highlight the positivity of it. Because I think in my time in gen med, I can't criticize ED for anything really. I mean, there's been some frustrations, but that's more of a systemic busyness and, that sort of issue, which is no one's fault. But I haven't had any sort of terrible referrals or anyone intentionally doing anything lazy or harmful in any way. If someone doesn't know what's going on, that's reasonable to say. I'm often, I'm very open to being unsure of what I'm doing half the time. So I think I'm open to, talking to other people and willing to listen to different ideas and get guidance, rather than criticizing someone's assessment in it. Yeah.
Yeah, I'd like to tease that out a bit because I think It's interesting, isn't it? Like the culture thing. I'm really interested in the culture of the hospital. Interested in it. I don't, you know, um, haven't done research on it or anything,
Yeah.
but yeah, because like I would just restate that I think everyone is almost all people are hardworking,
Yeah.
well intentioned, but there is an undercurrent, isn't there? Um, and sometimes it's more than that with regards to interaction between different services, which is definitely negative, and which I don't know, like it's certainly it's not often. Oh man, it's a bit interesting to speak about it in something that's been recorded, isn't it? But it's
Yeah.
certainly talked about a lot in things that aren't recorded, isn't it, Bish?
Yeah.
And
We've had these discussions
we've
before
had
on,
these
yeah.
discussions about the different parts and the interactions between them and attitudes and um, things like that. Not all of which is positive. And I don't really know what to say about it more than that. It definitely does exist.
Mm.
Um, it doesn't necessarily bother me on a day to day basis as much, but I'm in a very privileged position in the system as a white male doctor. Who's now more towards the end than the beginning of his training. So, yeah, they're very real issues in the hospital system. You see trainees and junior staff very upset often.
Yeah.
And that's not about patient care, that's about interactions and how those different groups
Yeah.
interact. And that's not good.
Yeah. It's interesting you mentioned about the position of privilege. I think I've been noticing that a lot, being out of my comfort zone, doing, gen med and neurology now, and even when I was doing palliative care. I think having been at Geelong for 5 years and knowing a lot of people in the hospital makes my job a lot easier than it would if I was unknown amongst other um, teams. And I would probably find it a lot harder to deal with as, my job. I think my day-to-day life would be a lot harder if that wasn't the case.
Yeah, I agree. And yeah, it was very interesting for me going to another hospital and sort of starting again
Yeah.
because you do get to the point where you get by
Yeah.
on being known,
Yeah.
whether or not you're making a good decision. It's interesting. It's interesting, Bish.
I think I just also want to highlight, there's been some new ED registrars that I've never met before who've been like really friendly. The referrals have been, lighthearted to some degree, friendly, and it's more than just a referral. It's a human interaction, which has been nice. It's not just, hello, I've got a patient you need to do some paperwork on. It's more like, hey, how's your shift going? Uh, you know, it's like, this is what I think. What do you think? Is there anything else you'd like me? Like that interaction is quite pleasant, and it feels like, it's a team effort. You're both sort of working towards the patient and making sure that the right management done. And I think that's one of the better parts of the job is to be part of a team sort of approach to appropriate patient care.
Oh, yeah, that's wonderful when you have those
Yeah.
moments, it's really great.
Yeah.
There's so much inefficiency though, like you'll see these patients who have seen a paramedic with 20 years experience with their COPD, who've had steroids and bronchodilators, who have ostensibly had the crisis averted,
Yeah.
who need a bed for a few days,
Yeah.
who then have uh, a member of ED nursing staff go through the story again, who then have a member of ED medical staff go through the story again,
Yeah.
who then have a member of an admitting team go
Yeah.
through the story again. And
Yeah.
it's interesting, isn't it, the way that
Yeah.
system works?
That's another thing about the gen med admitting job. It's like, I mean, a lot of the time, there's a well-written note in ED, on the ED notes that's done by a ED trainee or registrar or whatever it is. But I always feel like it's required of me to go through the BossNet notes again and dig through the history and make sure I haven't missed that, ED hasn't missed anything, which in some ways I think is reasonable. You guys are busy and don't necessarily, there are sort of time pressures. But sometimes if for the straightforward case, I feel like I'm wasting my time.
Yeah, definitely. And that must be difficult to get that balance right.
Yeah.
Because, yeah, I mean, I couldn't do a job where I had to trawl the notes too much. Like, it just
Yeah.
seems awful.
Yeah.
I think often it's more, be better off talking to the patient a bit, I think.
Hmm.
Mm.
Taking a different tact,
Mm.
what have your experiences with ICU been like?
I mean, I loved ICU, I think. I mean, I couldn't be an intensivist. It's not for me.
Hey now.
That might say more about me than I think about intensivists, though. I think all up, I've done a year in ICU. Yeah, I mean, what have my experience? I mean, I really liked it, Vish. Like, it was great work, you
Yeah.
know. I like that intensivists or ICU, it is that sort of, I like the generalism of it, you know, which I don't think, which it has in common with ED.
Yeah.
It doesn't, you know, they do get to see the acute critical part of a wide variety of illness. I don't know. I thought the doctors were smart. I thought the nurses were nice. I thought the patients were interesting. I enjoyed having time to talk to families and to go through that aspect of the patient's care. Um, ICU is good. ICU is good, but there's a lot that can be said about ICU, and
Yeah.
yeah, I'm here as an ED person.
What makes you say you can't see yourself as an intensivist?
Oh, I don't know. It didn't give me, for the same reason that I don't want to over intellectualize why I became an ED
Yeah,
doctor.
fair enough.
It just didn't give me the vibe.
Yeah.
Yeah.
It's a fair answer.
Yeah.
What about from an ED perspective, as as an ED registrar, what have your interactions been with ICU been like?
Um,
And to add on to that, has having done some time as an ICU registrar changed that?
uh, maybe. Yeah, because I sort of know what it's like on the other end where someone answers the phone who doesn't necessarily know what's going on,
Mm.
who doesn't necessarily feel that confident in their place in the system between the intensivist, who's ultimately responsible for their decision making,
Yeah.
and them as the person holding the phone, and the anxieties that can bring for that person holding the phone. I can have more of an appreciation for that having done it. Um,
Just to clarify that, do you mean the pressure of your decision making being criticised by or
yeah, as the ICU
yeah,
referrals reg,
yeah,
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 like that's a
sure.
tricky spot often.
Yeah,
Like if you're holding the phone
yeah,
from 8 p.m. till 8 a.m. while there's an intensivist on
yeah,
who's ultimately responsible for the minutiae of all of your
yeah,
decisions,
yeah,
and you're speaking for them, it can be a tricky spot to be in, I reckon, if you're unsure of yourself in that system
yeah.
and in that interaction. Um, I don't know, do you want to talk about how efficiencies in getting patients from ED to ICU or not?
Yeah. I think that's always a interesting conversation, I think. I mean, there's been lots of changes in the time that I've been here in as part of ICU about how that, even the transport process works, and that's the changes that have been made to that with it, ICU having to come down to pick up the patient and that sort of thing.
Mm. Well, what do you think? Do you think it's
Well, it's been a while, so 2 years since I've been in the ICU.
yeah
So I think I feel a bit out of touch to
to
have that.
comment?
Yeah.
Yeah, I mean, again,
And also from an ICU perspective, things have changed. When I last worked in ICU, the outreach registrar wasn't as permanent a role as it is now. And now there's even a outreach consultant that's being, during the weekdays that's on as well. So things are changing.
yeah, I'd be reluctant to comment particularly on the system we're in um, specifically, but I
Mm.
would say that as an ED doctor, I probably need to be careful in my expectations because you do sort of have your resus area full, and then you say that's an ICU patient, they're going to ICU, and then you want them to go like in a second.
Yeah.
So you have capacity for the next patient.
Yeah.
That's what you want.
Yeah.
Um, and you want ICU to be utilised to its maximum efficiency in the same way that your ED resus area is being utilised to its maximum efficiency. You
Yeah.
see if a patient gets stuck in resus for too long, you're like, oh, there's an ICU bed. Can they go to the ICU bed?
Yeah.
So that bed's getting used, and
Yeah.
that highly valuable resource of the ICU nurse and the nursing team
Yeah.
and the medical team upstairs is being utilised to its greatest efficiency. So you probably need to be a bit careful in wanting that, the patient to miraculously disappear upstairs, with understanding that there is a system and a process to go through. And the fact that there are times that I've been frustrated with that process as the ED doctor and had wanted the patient to move through the system quicker. And it's purely from that point of view, and that, you've got your critical care capacity in ED stretched at its limit. And if there's a bed upstairs, it's just like, it just it makes sense.
Yeah.
And it makes sense for the ICU to operate at its maximum, to, with all those expert nurses and doctors to do the most that they can do for the patients in the hospital. That's really the interaction we're talking about, isn't it? I
Yeah.
think.
Well, I guess it's that balance, isn't it? Like you say, ICU is a limited resource to some degree, as in there's a limited number of beds and number of staff as well. And in the short term, there's that bed available. Then you have to balance that out with turnover as well. And there's always that question of, if it's a patient needing non-invasive ventilation or, vasopressors for a short period, does management in ED for a bit longer prevent an ICU admission where they can go to the ward versus coming to ICU for a brief period of hours of vasopressors or non-invasive ventilation and potential bed block for a couple of days. I think that's a tricky one though, and it's and again it's a balance again, because there's that pressures in ED of waiting room pressure and seeing, like you say, providing care to the ones that are not getting any care, versus that resource for potential, which isn't, I guess, it's not as evident as a waiting room full of patients when it's a hospital full of potentially deteriorating patients.
Yeah, it's really tricky. I'm being more politically correct with this answer than I was being more. I'm probably towing the party line a bit more, I know, but yeah, I mean, I don't know. It's just like the ICU is just such a good resource, and it provides such good care to its patients. And if there's a patient who's appropriate to receive that care, everything should be done to get it delivered to them in as timely a fashion as possible. And that's all I can really say.
Yeah.
And I think as an ED doctor, I need to be honest in saying that I think the ICU is, largely wonderful, but there's definitely been times where it's like, oh, please, can you please look after this patient?
Yeah.
But then again, I don't have as much knowledge or experience with regards to the consequences of that from getting your ICU blocked, other than knowing that it's boring when your ICU reg and you're blocked up with.
A board ICU registrar is a dangerous thing, Chris.
Yeah. Other than knowing that, I'm sure there are also clever people who've analysed that.
Yeah.
In fact, I know there are, but I just don't know
And I think that for me, that's I don't have too many strong opinions on this because I've only worked in one ICU, so I don't feel like I have a strong position to make too many comments on it. I imagine it's going to be quite different in a different hospital with a different rate of turnover. So I don't feel like I've got enough experience to sort of make any strong comments on that. But I think it's something to think about, and for me at least, from my own practice. But on the other hand, I think, talking to you and getting that side of the ED side of things, to be mindful of, again, that team approach, like it's about the hospital flow as well. Is there anything I can do from an ICU perspective? It's not looking at sort of boredom down the track. That shouldn't be anything that,
No,
absolutely not. It should be, what can we do to help help the turnover in whatever way possible to make
Yeah, and
sure
to
the
help the
patient's safe as
patients,
well.
to help the
Yeah,
patients. I mean,
absolutely.
surely the in a day, the ICU team should be looking after the sickest patients
Yeah,
they can
yeah,
to their most efficient maximum capacity, whatever that may be.
yeah.
I don't know.
And I think my approach always has been, if there's a clear-cut ICU patient, we should do what we can to get them up as soon as possible. Um, uh, and, their management is going to be better in ICU than it is in ED. That's not a
No, yeah,
criticism of
that's right.
ED, where you have one or two nurses for 4 patients, whereas you have one-on-one in ICU. It's always, the management is definitely going to be better, as it should be. That's what it's designed to be. So I think if that is the case, then we should do what we can to make that transfer as quick as possible. But yeah,
Potentially, we're looking at it from the wrong perspective, aren't we, Vish? Potentially, we should be thinking about it from the perspective of the wards and, um, what it's like to have a sick patient in a ward setting.
yeah,
Um,
fair point.
uh, Potentially, yeah, we're
Yeah,
being, because, I was speaking to a patient who happened to work on a ward in the hospital who just, couldn't believe the resources that ED had.
yeah, yeah, right.
With like a nice new obs machine, for example,
Yeah,
perhaps we should be looking at it from the perspective of the wards as to how they feel when they're pushed with a patient, which is, compare the management between resus and ICU, then
yeah,
potentially between the ward and ICU.
yeah.
Is that where there's more of a divergence, you think? Like in like a HDU type setting, often that heavy patient, that medical patient with lots of infusions who might be only for a bit of HDU care.
So I think the more I've worked and the more experience I've had, there's the general policy of, if they've had 3 Met calls, they come to ICU, unless they're not for ICU level care, if that makes sense. Because as far as the protocol goes, at least in Geelong, they're supposed to have half-hourly obs for 2 hours after a Met call.
Mm.
And if they're having 3 Met calls in one shift, they're essentially an ICU patient. There's one-to-one nursing, really.
Yeah.
And that's not fair on the ward stuff in
No,
any
no,
way.
absolutely.
Yeah. And so I think that it makes a lot more sense. I think the more experience I've had, even if you've had 2 Met calls, I think essentially the plan from a Met call point of view should be that the first one, you should have a management plan. If that doesn't work and you've had a second Met call, unless you've got something that you're sure is going to avoid a third Met call, and if they're looking unwell, they probably should come to ICU from a resource point of view and a
Mm.
safety point of view, particularly on a night shift.
Yeah, definitely. And
Yeah.
that makes sense in terms of utilising the
Yeah.
resource that is the ICU for the good of the patients
Yeah.
overall in the hospital.
Yeah.
What I don't understand, Vish, is how, I just, with referring to all these specialties,
Mm.
including ICU, is there's so many ED physicians, there's so many gen med physicians, there's going to be so many intensivists. Surely you want to make your ward the most popular. Surely that is the model that works for your future employment. I don't know. You know? Like the idea that you want to say no and not, it's a ridiculous luxury of medicine
Yeah.
when we think about
Yeah.
having just gone through coronavirus shutdowns,
Yeah.
and being how glad I am that I didn't start a cafe.
Yeah.
It's a ridiculous luxury.
Yeah.
Mm.
What are you passionate about in regards to your practice?
Oh, I don't know, Vish. Yeah, I don't know. I mean, I'm not one of these guys I'm not going to talk to you about how amazing ultrasound is.
Hey,
Or,
it's the future. It's the future of medicine.
I mean, it's useful. I'm not a research guy.
Yeah.
I haven't done a master's of education and wouldn't profess to be that good at it.
Can I ask, is it expected from a ED training pathway to have like a non-clinical portfolio that you continue on as a consultant?
That's a good question. There's certainly a lot of talk and anxiety about people towards the end about their employability.
Yeah.
And there's this idea that if you've done a master's in something, or you've done some research in something, or you're good at something, then it makes you attractive to a potential employer. it's not an expectation of, I mean, there are lots of training requirements outside of your day-to-day work.
Yeah.
But you don't need to cultivate a portfolio as such
Yeah.
to get through the training. I think it's certainly something people look for when they're looking to hire, consultants. There's
Yeah.
two who are both the same.
Yeah.
And one happens
Yeah.
to be able to run a stats program or have an interest in research or have runs on the board in research. I mean,
Yeah.
but I think it's mostly motivated around employability
Yeah.
and jobs.
That's interesting because I think from an ICU perspective, I guess ED wise, most of your practice, it seems, even as a consultant, is clinical on the floor. At least that's the impression that I get. I could be wrong on that. But in ICU, I think the more senior you are, less time you spend on the floor, and it's your non-clinical things that become more important. And building that portfolio becomes more and more important as what do you add to the unit, whether it's research, education, whatever it is. It's about building that the unit and being a component of that.
Yeah, I mean, I got really anxious about not, having an ultrasound degree a couple of years ago because I sort of thought I should have something, but it's got to be organic. It's got to be natural. Like it's got to actually be something you're good at or are passionate about or there's an actual need for or a resource. I think it's got to be very sincere in terms of what you bring.
Perhaps in a different tack to that similar sort of question, almost an interview sort of question.
Yeah.
What are you proud of about your own practice?
Oh, no.
All right. Fine. That's too wacky.
I don't think any of my answers to the questions would have suggested I was going to answer that well.
No.
What am I proud about in my practice?
Yeah. You don't have to answer it.
No, that's
You made me
terrible.
feel bad about that question. I'm going to stop. I'm going to take it out.
That.
I'm going to never ask that again. Thanks, Chris.
I can talk about people I admire whose practice I would like to emulate.
Yeah, fair enough.
Who comes to mind at the moment? I mean, there are people who are just tireless patient advocates who don't really get anxious or don't outwardly appear to get anxious or worried or stressed about how it makes them look. I mean, those people are really admirable.
Yeah.
I've seen people go into bat for junior staff, like a very senior consultant ring up a registrar saying, "Why are you giving my intern a hard time?" Like that.
Yeah.
Like I love that sort of stuff. I love seeing people do that.
Yeah.
I like people who are really, I mean, there are ED consultants with 30 years experience who still have to see tummy pain, and chest pain. Like it's still very hands-on and clinical in a way that, I don't know, you wouldn't want to lose that. I wouldn't have thought,
Yeah.
Yeah. Still getting stuff out of people's eyes, with 30 years in the game.
Yeah. What are your interests or commitment? What takes up your time outside of work?
Oh, Vish. Oh, well, I have large, sizable commitments. And I should paint the picture that I'm sitting in an absolute bachelor's house at the moment. With evidence of all these hobbies I just didn't even realise existed.
I've forgotten a lot of them as well when I was studying and trying to relearn them.
Yeah, that's good. But I'm working or studying or spending time with my wife and children and the very simple pleasures that entails. I mean, George and Rog are 4 and 2, and it's just so much fun to hang out with them and to kick balls and run around and ride scooters and play. It's the best bit. So that's largely what my time. I mean, I'd love to have a hobby. I mean, it's a matter of time before I go full white male doctor and buy
a bicycle.
No, it's a matter of time. But we'll watch that space.
How do you, I think you alluded to it earlier about balancing this with, particularly while you're studying and how it's different now to, your previous exam. How are you managing that at the moment?
Oh, some days are better than others. I mean, some days are better than others. I think overall, I don't know, like I need to see my kids every day and spend time with them every day, even if that's just getting home for dinner and then putting them to bed. I mean, that's Um, that's kind of a requirement of my job, and I wouldn't want a job where I couldn't do that.
Yeah.
Um, and so I maintain that even in study. But it's largely consuming, and I think it's probably more important to have a bit of perspective on that and acknowledge that overall, all things going well, in 5 years' time, I'll look back on the previous 10 years and think overall it was pretty balanced and it wasn't too far off. And there will be times in that where I was working harder and a bit more stressed, and times in that when I was working less harder and a bit less stressed. But overall, it will even out.
Yeah.
And then hopefully it settles on a nice, um, livable keel.
It's a very insightful sort of outlook on it, I think.
Yeah, I mean, like it's not, you got to be careful as a doctor, to not think you're too special. You got to be really careful with that. And there's a lot of
Yeah.
people who, and I wouldn't say that I've nailed it, but you're not special. Try being an accountant, doing your CA,
Yeah.
and try running a small business as a tradesperson, working many, many days a week, starting very early and finishing late. Try all of those things, and it's you've got to be a bit careful.
That's interesting. So I hear, a lot of medical people talking about how their non-medical friends don't really understand their job and the pressures of it all. Whenever I hear that, I'm like, well, if I talk to a non-medical person, friend of mine, and they tell me about their job, I don't understand it at all, and I'm often in amazement of how they manage it. Sometimes, it's in the context of saying that we're not special. Like everyone works hard in their own way, and every job has their own sort of pressures and stresses that go with it.
Yeah, you got to be really careful, Vish, because I couldn't agree more with you on that. And yeah, that's something. So I've deliberately not made generalizations or casted dispersions, but I think you could generalize in saying, doctors are a bit guilty of thinking they're a bit special, but they're not, and you're not.
Yeah.
And yeah, I couldn't agree more with you on that, Fish. I couldn't agree more with you that, particularly in this current era where a whole heap of people have just lost their jobs. I mean, really, it's not.
Yeah.
It's
I think that was something I had on my mind, being a bit uninspired at work, having to remind myself I'm lucky that I have a job.
Yeah, no, that's right. I've changed my opinion on our earlier discussion. I have a very clear opinion on our earlier discussion here. Yeah.
What's your approach though with, balancing family and study and work stresses? Like you seem to have like a long-term outlook on it, but in the short term, how do you deal with stress and balancing it?
Oh, how do you deal with stress? I don't know. Some days not that well. Yeah, to be honest.
This is partly reflective and partly also, I think, again, from an outsider's perspective, you seem to be dealing with this. You seem as someone who's well-rounded and manages all this quite well.
Yeah.
So I'm trying to learn your secrets, essentially.
Oh no, but it's easy when you've got a family. You've got this thing outside of work which demands attention, which has to be done well. Which you have to put time and effort into, which you love. So it immediately gives you something outside of work, which can perhaps give you some perspective on your day-to-day interactions and stresses. But yeah, I don't know. Like I'm going through a phase of eating a lot of chocolate, of not going on many runs, of sometimes not sleeping enough, and so it's really got to even out.
That's the opposite of interview answers for how to
Yeah, I
manage
know,
stress.
isn't it? I know. Yeah, but I mean, it is the real world a bit as well. But I think the idea that it's a period of intense effort, then with reward at the end, where you can refocus and adjust to what's important. But you got to see people, like you've got to talk to your brothers. Like my wife's wonderful, like gets people around for social talking. And you've got to do things that are fun.
Yeah.
And you've got to have time where you don't work at all. And I'm not on social media. That's probably one of the very few things I'm proud of about my life is I'm on no media. And I just think that's poison. That's bad for you.
Yeah.
Yeah, they're my only insights.
Do you find it difficult at all when not studying for exams to balance family and work?
No, no, no,
Yeah.
no,
Okay.
no, it's good. Yeah, because an ED is great. Like if you can do it, if you can switch off and leave
Yeah.
and then have days with your kids, ED is great.
Yeah.
Sometimes a bit tricky about switching off and leaving. You're sort of left with lingering thoughts.
Yeah.
That's the challenge. But no, no.
Yeah.
I would like to be a bit fitter though
After the exams.
after the exams. Yeah.
Um, so it sounds like, from all the answers you give me, it's like family seems to be a big
Mm.
part of your life. How do you put work in the context of your life? So how does that fit in?
Oh, that's a good question. Because it's obviously very important. Because I put a lot of time and effort and years into my work and
Yeah.
take great pride into it.
Yeah.
So, but I'm not
And that
going to.
shows.
Yeah, but I'm not going to rank things. But yeah, work's really important. Having a job which you take pride in and do well is really important. Yeah. Or try to do well. That's as important as doing
Yeah,
well.
absolutely.
Yeah. Did that answer your question? What was your question?
How does work fit into your context of your life, really? It's not about, I guess, ranking. I guess
Yeah.
for me, for example, at the moment, work is a priority. That balance of family and work isn't an issue at the moment, whether I'd like it to be or not. And I couldn't, like you say, I would not be satisfied if I didn't have a job that I was inspired by and, wanted to be there and, excel in and work on and improve. And that career progression and progressing myself and my learning is something that I value a lot.
Yeah, no, I couldn't agree more. Like, and that is the best thing about our job. I
Mm.
mean, and as a career, like that's hugely attractive.
Yeah.
And there are so many luxuries in this career. Just, this is going out to medical students, isn't it, Vish? Like, it's just
Yeah,
like it's
as
just
well.
it's just like the best job. To have something which you can work at and do well at
Yeah.
over years and give as much or as much time as you want to. It's a great job.
Yeah.
It's really good from that point of view. And it's a luxury to have a job where you can do that.
Yeah.
Yeah.
Has your work as a physician, as a doctor, sorry, impacted on your views on life or on people in general?
Well, yes, it has, but that would be hard to summarise.
Yeah.
I've probably, however, been guilty of being slightly cynical. Not cynic. Cynical's the wrong word because I don't think I'm a cynic.
I don't think so either. You don't come across as
Not cynical, but of being because you probably in ED you see a lot of people who are sometimes having their worst day, whether that be because they're in pain or suffering or scared. And so you do have to be careful that is just a glimpse of people. That is not how most people are operating. I'd certainly pull over if a car comes up behind me fast on the freeway. I'm like, yeah, no, some sort of angry, person.
Yeah.
I certainly, it's changed the way I drive on the freeway. I don't take risks anymore. No, with other people, other drivers.
right.
Mm.
Because of the trauma and stuff you've seen. Is that what you mean?
No, because of the drug affected people I've seen.
Right.
Yeah.
right.
I just think there's you don't sort of you just you let the tailgater through.
Yeah.
You don't know what's going on there.
Yeah.
Mm. But yeah, I mean, I've had to be careful with that, and that's something my wife's pointed out to me. Is, you just got to be careful with my perspective and my portion of the population that I see.
Yeah.
which might have been an advantage of something like general practice in terms of, I don't know, again, generalising about a specialty I mightn't know that much about. Maybe you see more of people when they're better or well. I don't know.
Yeah.
Mm.
Interesting. What does the future hold for you? Sounds like exams.
Exams,
something.
yeah, exams. So it all sort of hinges on the exams, really.
Yeah.
I really hope I get through them.
You will. I'm
Yeah.
very confident of that.
Thanks for sharing. No, I mean, I'm really looking forward to it.
Yeah.
And then I've got to get a job, and that will be where it will be.
Yeah.
And I don't know where it will be. And then hopefully I can work. I mean, the ED consultant dream is to do 3 clinical shifts a week, 1 non-clinical shift a week, where you get to do something interesting in your non-clinical time, which I think there's a bit of a knack to. And then not work every second weekend. Work less weekends than every second weekend.
Yeah.
Because my kids will be starting school soon. There's a limit to that. And yeah, then probably just a bike, carbon fibre.
Have you picked a name?
For my bike, no. No, I haven't.
What about the Lycra? You got to invest in that too, don't you?
Yeah, you got to go big in the Lycra. There's some very expensive shorts, is
Yeah.
my understanding.
Yeah.
Hundreds of dollars.
And
actually.
apps to join. You might have to do the social media after all.
Oh, no.
So you can post the rides that you've gone on and how many
Well, yeah, how
kilometers
does
you've done.
social media affect your life? Does it positive or negative or not?
It's a big question. I am limited in how much I use social media too. And I think I think I've definitely felt negative effects of it. And I think I've drawn myself back from it a lot more in the last few years. So I don't use Facebook. I used to just use Messenger. I think there's utilities, with contact with people, particularly when you've got family elsewhere and all that, overseas and all that. I think there's value. There is positive to social media. I think it's how you utilize it. So I just have to be conscious of what I do with it, and not sort of spending too much time or anything. And I don't think I'm too bad with it. But certainly sort of drawing myself back and trying to sort of have more, face-to-face conversations and yeah.
Do you know what I read about today, Vish, on a completely different note, was Philip Hughes. Do you remember when Phil Hughes died?
Yeah.
The cricketer?
Yeah.
I don't know why I was reading that story again, but that was just that was... Are you into cricket?
Yeah.
Yeah.
Of course, I'm Indian. It's in my blood.
No, but it would be worth, because he died around this time of year, and I was just reading about it today. He was 26.
Yeah.
He wasn't even 26, he was 25. He was hit on the head with a cricket ball and killed.
Yeah.
And that video where you see him collapse, it's just like he's unconscious before he hits the ground. That was just so sad. As a kid who grew up watching a lot of cricket, who was an Australian cricketer in the backyard many, many times.
Yeah.
Yeah, it was just so sad.
Yeah.
On a completely different note.
What made you read about it?
What was I reading about? I think I was in some sort of Indian summer of cricket to a spiral on the... Yeah.
Yeah.
Yeah, it was just so sad, because he never got the opportunity, he never got to test his full potential.
Yeah. It's a scary thought as well, isn't it? I mean, having played as well, and the ball is hard, and that it's coming at you at over 100 kilometers an hour, despite having a helmet or not. That's a scary thought that it is actually a deadly thing that you're doing.
Yeah, well, I remember when it happened. I was a junior doctor at the time, and he got hit on the head.
Yeah.
And it was just lots of people were really upset by that. I think who'd probably had similar aspirations for their own, who sort of identified in that strive to be an Australian cricketer, I suppose.
Yeah. Family-wise, anything else on the horizon?
We're getting a dog.
Oh, yeah?
We're getting a dog. We're 10 days to a dog.
Yeah.
Has your cat just run away? Is that what's just happened?
Has she not convinced you to get a cat?
No.
She hasn't scratched your foot.
I'm not anti-cat. I don't have a problem, but I didn't want to scare her off by the mention of a dog. Yeah, so we're getting a lab.
She doesn't speak English. Yeah.
We're getting a lab.
Yeah.
Which will be nice.
Sure your kids are looking forward to that. Yeah.
Be good.
Well, Chris, thank you so much for doing this. I really appreciate it. It's lived up to what I expected it to be. I think it's been very insightful, and certainly useful for me and hopefully to people listening as well. Any other thoughts or anything else? Any parting words of wisdom?
No, Vish, thank you. I'm very flattered to have been asked to come and talk to you.
Thank you, Chris.